As Susan said, this is a bit of an experiment. We are trying to figure out a way to give all of the information that we have about these diseases, how we diagnose them, how we treat them, what we hope we'll do for them in the future. We're trying to give all that information to the students who come here, as well as caregivers who come, people who attend the Lunch and Learn, just sort of at different levels. So we're going to talk about brain imaging, which is complicated. I'm not a radiologist, nor would I be, because this is so complicated. And try to deliver the information in a way that's useful to you, but still gets the science across. So we'll start out by just talking about why we get brain images. What's the point of getting brain images? Then I'll talk more specifically about imaging, particularly imaging that we use to diagnose people in the disease that we treat here. And then future trends, things that we hope or expect to happen in brain imaging over the next several years. And I'm glad to see that we have a couple of the people who actually do the imaging work here. So if I have questions, I'll just call on you. Please interrupt if you have any questions. I cannot see the people in the remote sites, so if the people here can, if someone raises their hand or something, let me know, all right? So why do we get brain images? When we look at brain images in neurodegenerative disease, most of the time we're doing it to diagnose, to establish a diagnosis, figure out what is going on, what's causing the symptoms that the patient is having. In the past, particularly with Alzheimer's disease and other cognitive disorders, we mostly got imaging to exclude non-degenerative disease. So we would get a CT scan of the brain, and the reason for getting that CT scan was mostly to make sure that there wasn't a tumor or a series of strokes or some bleeding in the brain that were causing the cognitive symptoms. Now, in addition to doing that with imaging, we also have ways of looking at the images that can give us information about what the correct diagnosis actually is, and we'll look at some of that as we go on. But there's another important reason for getting brain images that is not as important in our diseases yet, but we hope will be in the future, and that's for monitoring what's going on with the disease. So we know that, for example, with Alzheimer's disease, that the brain progressively gets smaller. Particular parts of the brain tend to be affected more than others. And if we're going to treat that shrinkage of the brain, if we're going to treat the loss of tissue, then we need to have some way of monitoring whether tissue is being lost or saved. Right now, because we don't have any methods of actually stopping the tissue loss, we don't typically use repeated CT scans or repeated MRIs to follow the disease progression. We have ways of treating the symptoms, and so we generally monitor symptoms, cognition, behavior, and so forth. But presumably, pretty soon, we'll have ways of attacking the disease itself, and so we'll need imaging to tell us whether what we are doing is working. Another reason for using imaging in neurology is to evaluate for normal development over time. So this is mostly naturally in pediatric neurology, where we're looking for certain structures of the brain to form or define themselves as a normal course over time. And in fact, I saw a gentleman here who was about 30 or so, and he had an MRI that was perfectly normal for a 5-year-old. So because he hadn't developed in the way that we typically would expect a brain to develop, that gave us information about what disease he was suffering from. We'll talk about some terminology that may pop up as I'm talking about brain imaging, or that you may hear in clinical situations. So we talk a lot in imaging about resolution, and resolution is kind of like, with a camera, the smallest amount of detail that can be perceived by whatever measuring device you're using. There are different kinds of resolution. In imaging, because it's visual, we're mostly interested in spatial resolution. What's the smallest amount of space that we can see with our imaging device? But we're also increasingly interested in what's called temporal resolution. How quickly can the device measure changes that are going on, in this case in the brain, but in whatever you're measuring. Contrast in general just means the difference between two things. In radiology, we use contrast dye or contrast fluid. And what that does is enhance the differences between structures to enable us to get a clearer look. And there are some things where contrast is helpful and some things where contrast generally isn't. Tomography, so that comes up in the abbreviation PET, which is positron emission tomography, and SPECT, which is single photon emission computed tomography. Tomography just refers to slicing things in parallel sections. The reason I bring that up is because that's the way we display most of our neuroimaging. And that's because that was the way that we did anatomy. We'd slice things up and then follow the pieces through, and that's how we'd figure out what went where and why. We don't actually have to display things as tomography anymore. So there may be some point at which we're doing a lot more of displaying things, not as tomograms, but as actual 3D images. And we have the capability to do that now. We just aren't using it very much because we're very used to these tomographic pictures. But that's why, you know, when you see a picture of an MRI scan, that you're not looking at a brain, you're looking at slices through the brain. And then radiation. Radiation is energy that's emitted by nuclear decay. So a nuclear isotope, which is a radioactive atom, as time goes by, it releases energy. And that energy we use in several ways in radiology to give us images. So we should also talk about the body planes, because the way that we do most imaging is in the axial plane. So that means slices this way that divide you into a top segment and a bottom segment. Does that make sense? But we can look at images in other ways. So we can look at sagittal slices, which divide you into left and right portions. And we can look at coronal or frontal slices, which divide you into back and front. Most of the time, as I mentioned, when we're looking at scans, CT scans, MRIs, we're looking at axial, but we have the capability now to look at things in any plane. MRI is unique in that when the image is acquired, it's actually acquired in all different planes, whereas with the other types of imaging, it's acquired in the axial plane, and then we change it around or we do processing so that we can see other planes. So CT scan. CT scan is really an advanced kind of X-ray. So what happens is that we shoot some particles or waves, depending on how you think of energy. You shoot them at a substance, and some of them will go through, some of them won't. The ones that won't, the thicker or the denser the substance is, the less likely are those particles to go through and create the image on whatever is capturing the image in the back. We'll just call it film for right now. So if you shoot one of these beams through air, you'll get a really good image. You'll get a lot of image creation on the film. If you try to shoot it through a rock, you won't get a lot of image creation on the film. And the film in X-rays turns dark when there's a lot of image creation. So darker areas are areas that are less dense, and brighter areas are areas that are more dense. And you're basically looking at an inverse of a shadow. The first CT, anybody want to guess when the first clinical CT was done? Just, it's okay. We're not putting people in jail if they get it wrong. 1980? That's a pretty good guess. That's pretty close, actually. But earlier than that. 72, good guess.
World War II.
Huh?
World War II.
No. 1971 actually was the first clinical CT. But you'll notice that the time that you started hearing about CT scans was probably quite a while after that. I mean, when I went into medical school, we had just barely started using MRI, and I'll tell you when those came about. But these are all relatively new technologies, but maybe some of them aren't quite as new as we thought. So here's a picture of someone getting an X-ray. Oh, my arrow isn't working. Oh, yes, it is. So you have an X-ray emitter, and that shoots the X-ray beams, and you point it at whatever tissue you're trying to image. Some of the beams will go through and hit the film, some of them won't. So what we're basically looking at is a shadow of the density of this person's chest. And this is what a chest x-ray looks like. So the bright stuff is where a lot of x-ray did not go through. So the denser materials like bones, and denser material like the bones, like this is the collarbone here, the two collarbones. You can see the spinal column back here. Less dense stuff, such as soft tissues, the muscles under the shoulder, the heart muscle, the diaphragm, which is right here, coming across here. And then stuff that's very, very not dense, stuff that's very not dense, like air in the lungs. So that's how you can define the lungs, and you can see them contrasted against the very dense ribs that are going across. And this right here is a bubble of air that's in the stomach that we use to identify the location of the stomach. So there's usually a bubble of air sitting on top of the fluids in the stomach. One of the things that occurs, or one of the things that's problematic with an X-ray is that although it gives us very useful information, it does not give us information about depth. So what's going on here? There's scissors here. Where are these scissors? Are they in his? So I hear inside, outside, laying on top. Well, I know, but eventually we'll all know. But that's the problem with X-ray. These scissors could be 2 feet in front of this person. It could be sitting right on his neck. He could be lying on top of the scissors, because all you're getting is the shadow, right? And shadows only give us information about 2 dimensions. They don't give us depth information. In this particular case, we take another angle and we can see that actually it's inside his neck. But you can't get that information without taking 2 different studies. And you have a similar problem with this fellow, construction worker, who, this is the story, I don't know if it's true, came into the emergency room complaining of a severe headache that he had for a day. And they took the x-ray and they found out that he had shot a nail through his head. But this is also inside, went up sort of just outside of the gum. But again, you can't tell, is this nail lying on his head like this? Is he lying on the nail? Or is it in the middle of his head? So with multiple angles, you can actually start to define this 3D information. So if you look at this woman here, there's light coming from in front of her, and the light coming from in front of her gives us a great shadow of her arm out holding the banana, but we get no information about this pineapple that she's got in the other hand. Pretty big object, you know, if some pineapple size was in your body, you'd sure want to know about it. But we don't get that information from a single point of view with the x-ray. Now, if you add on another light source and another place where you can capture the image, now you get that information. So now you can see that she's got her hand in front of her, she's holding a pineapple. But this image is not good enough either, right? Because with this image, you can't see the arm and the banana. So you really need both. What would be ideal would be if we could put lights all around her and then panels all around her to capture the shadows. But that's not a workable solution either, right? Because if you put a light right here, then it messes up this shadow. If you put a light here, it messes up that shadow. So you'd theoretically be able to get more information, but the light sources themselves would take that information back away from you, because you need, if you put light in a shadow, you're going to lose the shadow. So what someone came up with was, how about instead of having a bunch of lights and a bunch of panels, we have one light, one X-ray emitter, and one recording device like the panel over here. Oops, sorry. One recording device that's like the panel that the shadow is on. And then instead of having a bunch of those, we take those and we rotate them around the patient. So that's essentially what a CT scan does. It's like an X-ray, where you have the X-ray emitter and you have the film, but instead of just taking one picture, you take hundreds of pictures as the film and the emitter go around the individual. So you're getting all of these shadows, which then get put together by a computer to give us an image that has multiple dimensions. And so this is what a CT of the chest looks like in comparison to an X-ray of the chest. So now, where we saw the heart as kind of a big blob, I don't know why I can't get this cursor working consistently. Where we saw the heart as a big blob, now we can actually see some more information about the heart. So here's the heart, and you can actually see separate chambers. You can see that chamber there, and it's filled with bright stuff. What's the bright stuff in there? Blood. Why is it bright? Why is blood bright? It's a fluid. Why should it be bright? Bright means that it's dense, right? How can this fluid be more dense than the tissue around it? Why would blood be dense? What's it got in it? It's got oxygen. Oxygen isn't so dense. Iron. Yeah, the iron in the blood actually makes it somewhat dense to the X-rays, and so you get a bright signal. Here's one of the lungs, the black because it's filled with air. And again, where you could only see the lung as sort of this panel before, now you can see how far back it extends. So these are axial slices, as if someone was slicing through an individual from top to bottom. CT scans are still, though, maps of density. So they're like X-rays in that they're still just showing us the density of different tissues. So when do we use CT scan in neurology? It's not still the preferred image. So maybe 15 or 20 years ago, the CT scan was what we always used in neurology. Now, we tend to prefer MRI, but there's still some situations where we actually prefer CT. So when speed is important. Has anyone here had an MRI? How long did it take? An eternity. Yeah, so usually, especially when we're doing complicated brain images, MRI scans take at least a half hour or so. These images that you see of the brain and skull here, probably the time it took to acquire the image would be less than 5 minutes, would you say, Elaine? Yeah. I'm trying to get my arrow again so I can show you these different structures. The other thing that CT can be used for is to assess trauma. And there are a couple of reasons why we want to use CT to assess trauma. One is because usually when there's a trauma, we want to get our information quickly, right? So the speed comes in again. But the other thing that's important is that CT is very good at picking up bone and blood and picking up the difference between bone and blood and the other structures around them. So for example, here, this is bleeding in the brain, probably occurred because of high blood pressure, and it picks up very nicely that there's blood in the brain. You can also see that there's sort of a dark halo around it where there's been some swelling, just inflammation of the tissue because of the bleed. Here's a more serious problem, well, more severe problem, let's say. This individual has blood crowding in on the brain from there and from there. You can also see that he or she has a lump on the head. And if you adjust your contrast and your brightness, you can do what's called bone windows, and you can get a very nice picture of the bone, and you can see this crack where there's less density because there's a discontinuity. The bone doesn't continue all the way across. There's been a fracture of the skull there also. The other times when we use CT in neurology is when we cannot get an MRI. And there are various reasons why it would be difficult or impossible to get an MRI. We'll talk about that a little bit more when we talk about MRI. Why not always use CT? It seems to provide pretty good information, and that's true. And we did used to always use it. But one problem is that density doesn't give us all the information we need. So this looks like a pretty normal brain. with the tissue going all the way out there, no blood, etc. But if you put in contrast, I'm not sure how easy this is to see on the screen, but you can see that actually the brain ends right here, and this gray stuff outside of where you see the white ruffles, this gray stuff out here, that's all blood. And the reason it looks like that is that as blood sits around, it becomes less and less dense, so it becomes less and less bright, and it passes through a phase where it's exactly the density of the brain tissue. And so to a CT scan, because all it knows is how dense something is, blood looks exactly the same as brain because the density is exactly the same. As you can see, in this particular situation, density does not give you the information that you need to have. Also, because, again, it's affected so much by the density of tissue, areas that have a lot of bone around them, like the base of our skull, or even our spinal cord, which is surrounded by the spinal column, those areas cannot be imaged quite as well as we would like, because even though we get great information that there's a big piece of bone there, we don't get much information about what's beyond the bone because a lot of the rays get stuck in the bone, right? They don't pass through bone. That's the whole point of it. And so we don't get to see structures that are very small when they're encased in a lot of bone. And even though CT scans are beautiful, I mean, these two CT scans here look almost like if you sliced open someone's head and looked at their brain the last time you did that. Even though you get these beautiful pictures, they're not as good as the pictures we can get with MRI scan. So MRI stands for magnetic resonance imaging, and it's important that you realize it's not based on X-ray technology. So MRI is a technology all to its own, and that's somewhat important because it doesn't require exposure to ionizing radiation, which is the kind of radioactivity or radiation that we worry about. What it does is it actually, in a way, reads the characteristics of the tissue. So almost all the tissues in the body have hydrogen in them, and the hydrogen acts differently depending on what kind of tissue it's in. And basically, we use that property to give us images of where these hydrogen atoms are. When do you think the first MRI was performed? Guess? Before or after 1971? After. Good, good. How long after?
25 years.
20 years. 5 years. 5 years. 10 years. Wow, I thought it was going to be something like 20 years. It was actually about 6 years later. Yeah, 1977 was the first MRI. And there's a little story. I guess the guy who invented the machine, he thought it is a great invention, and he got in it to try the first MRI, and it couldn't image him. And he didn't know what was going on. He thought maybe the technology had failed, and one of his students said, I think you might be too fat for it. And he got out, and someone skinnier got in, one of the students, I believe, and it worked. But one of the problems with MRI is that it's this very narrow tube that some people literally can't fit into. And depending on the strength of the MRI, usually the more powerful the MRI, the narrower the tube, and the harder it is to fit in there. So we have these giant machines, right? If you haven't had an MRI, have you seen one? Seen what the machine looks like? So it's an enormous structure. And it's not just the imaging machine itself, but it's all the stuff around it, right? You need this whole room for an MRI scanner. Well, what is all that garbage? Sorry. Sorry, Trish. So the big boss of the whole setup is the magnet, is the main magnet. Now, the Earth has a magnetic field, right? We all know that's how compasses work. Anywhere you stand on the Earth, you pull out a compass and that magnetic field will pull the needle around. And the magnetic field plays with little things in our lives all the time. That is about a 0.5 Gauss strength magnetic field. Gauss is how you measure these things. Our magnet, is our magnet 3.0 or 3.0? Our magnet here is 30,000 Gauss. So that gives you an idea. When we say there's a strong magnet in there, it's a seriously strong magnet, and that creates some problems. Also inside that big tube, there are radio frequency coils that generate a radio frequency pulse. And then there are other magnets that are smaller, but also quite powerful, still thousands of times more powerful than the Earth's magnetic field. And it's those magnets that you hear switching on and off. That's the hammering noise and stuff that you hear. And then there's a cooling system because the big magnet is a superconducting magnet, which means that in order to drive the electrons through at a rate that's fast enough to create this strong magnetic field and at a cost that's manageable, we have to cool everything down very, very low so that the electrons move through efficiently.
Excuse me. Now, when you say the 30,000 gauss causes some problems, you went away from that.
Mm-hmm.
Is that problems with the person that's getting the x-ray or problems how?
They're secret problems.
That's not a good answer.
No, well, problems with, so if you were to go back into our imaging suite, first of all, you wouldn't be allowed anywhere near the MRI room without someone with you.
Exactly.
And the reason is that if you go in there with metal, you could have another secret problem, which is that the magnet could potentially suck the metal right off. So there have been stories of people actually dying, oxygen tank going in the room or cleaning equipment going in the room and just getting sucked up by the magnet. Remember, this is, you know, several thousand times the strength of the Earth's magnetic field. And that causes, you know, some problems or some difficulties, let's say, other than just errors. You know, if someone mistakenly brings metal in there. I'll tell you a story which I don't think I've ever told before because I could have gotten in real trouble. I was, when I was working as a researcher in magnetic imaging, I went to help a subject get into the magnet once, and my arm kept getting pulled toward the scanner. And I thought the subject was doing something, was like tugging on my arm or something like that. So I didn't pay much attention because, you know, it's just a person. And, but then I realized as I came out that I was still wearing my cufflinks and my arm was getting sucked into the magnet by the cufflinks. So, you know, imagine an oxygen tank or something like that. And we'll talk a little bit, sorry?
Yeah, silver.
Come right out. No, there are only certain types of metal that are affected. You know, the same way that if you got like a refrigerator magnet, and some metals it'll stick to and other metals it won't. So it's ferrous metals.
About braces, I mean fillings.
No, fillings typically are not magnetic. Typically a magnet won't affect them, yeah. Silver, I'm pretty sure, won't be affected by a magnet. Gold shouldn't be affected by a magnet either. It's generally things that have iron as part of their makeup.
What about posts, metal posts that are in your teeth?
I don't think those usually have iron. I really don't know for sure, but I'm pretty sure that those wouldn't count. Why don't we just go over and we'll see.
Oh, somebody's
A
raising their
question from one of our remote sites.
Yeah, so someone said her husband had wire.
That's Sue.
Surgery that was lifting. Yeah, hi.
Hi.
So they sewed him up with wire that stayed
Uh-huh.
in his body after heart surgery.
Yeah.
Would that,
The wire that they're using nowadays, I don't think is ferrous or iron containing, so typically is safe. The big dangers are pacemakers, not only because they have metal in them, but because people turn pacemakers on and off actually with magnets. That's how you turn a pacemaker on and off, is with a magnet. And this magnet's big enough to turn it on or off. And we worry also about clips on blood vessels, aneurysm clips, particularly when they're in the head, but we have to worry somewhat even when they're not in the head. And then not only does the magnet pull on metal, but it can heat the metal up. So sometimes if you have metal in other parts of your body, stents in the heart, if they haven't been tested for this magnet strength, then you can't use those. So those are the problems that having the magnetic field creates. So you don't have radiation, but you do have to be careful with metal. So what happens in an MRI scan is complicated, to say the least. But the way to think about it is that what we're trying to do is basically generate some way through which the atoms can release energy. And we can pick up that energy, we can sense that energy, and then make a picture out of it. So The big magnet, when you go in there, actually your hydrogen atoms all line up, north, south, north, south, north, south, for the most part. Some of them aren't matched up, so there's an odd number of hydrogen atoms. Some of them aren't matched up. And then we blast with a radio pulse. That pulse provides some energy to the atoms that aren't matched up. When the pulse is taken off, they start releasing that energy, and it's that energy that we read and use as information to tell us what type of tissue we're looking at. And then a computer program basically creates an image out of those data. So this MRI scan, some of the advantages, all of the information is done in multiple planes. If you want to get a view of the brain that's slanted on a 45-degree angle, you can set up the MRI scan to do that. If you want to get a view of the brain that's, straight along sagittal plane, like the one on the bottom left, we can get the MRI to do that. And when you can see when you look at this how much detail there is. For example, in the picture on the top left, we can actually not just see the brain structure, but you can even see the difference between the gray matter and the white matter. If I could get I'm just going to do it with the pointer. So you can see that on the outside of the brain, it's literally gray, and deep in the brain, literally white. And that's the way the brain sort of looks in real life. And in this particular example, we're looking at a part of the brain called the hippocampus, which should be right here, like it is on this side. But this person, their left hippocampus, this is the left side, the left hippocampus has shrunken quite a bit. And so we can get really great detail for looking at small structures like the hippocampus. Also, we can emphasize different tissues. So with MRI, in addition to the great structural information we get, we can change the type of pulse we're using, the timing of the pulse, and the timing of reading the energy so that we can see different features of the tissue. So for example, here we're doing what's called a T1, a mostly anatomical scan that looks a lot like the brain itself. If we want to emphasize fluid in the brain, then we do a T2 scan, and you can see now that these fluid-filled areas of the brain, the ventricles and the sulci, are white. So the MRI scanning allows us to actually emphasize different characteristics of tissue, where the CT scan, density is it. That's the only thing that you can get information about. So why not always use the MRI? Well, in addition to the metal issues, it usually takes longer, although we're getting faster and faster MRI sequences. So if someone can't tolerate lying on their back, let's say, if they have a bad back, or if behaviorally they have difficulty staying still, or if they have a really bad tremor, then MRI may not be a good technique to use to look at their brain. The tube is narrow, and some people have claustrophobia. My dad got about up to here in an MRI scanner and ran out of the room screaming he has bad claustrophobia. Sometimes we can't get an MRI scan because of claustrophobia. And as I mentioned, it takes longer for now. And then there are the safety issues that are mainly because of the strong magnet that's in there.
Isn't it very loud too?
It is. That is not typically a reason to not do it, but people are often very bothered by the loudness. And
People say it's extremely loud.
oh, it's extremely loud.
It's like you have to wear earplugs.
We always put ear protection on patients here. I can't imagine anywhere that doesn't, but could be.
How much time does a typical MRI last?
Oh, I would say typical is 30 to 45 minutes. Does that sound about right, Trish, for the average? There's some that are longer, and like I said, there's some sequences where we can get the data with much shorter intervals of time. Nuclear medicine, we'll go over this quickly, it gets less, that's right. Elaine is going to come up and give an addendum after I give my part about nuclear medicine. These are positron emission, or PET scans, and single photon emission computed, or SPECT scans. And what we're doing with these is that we take a radioactive tracer, which is a chemical that has some kind of biological activity in the body. And we put on that chemical some kind of radioisotope, so some kind of, some atom that's got nuclear energy. So the one I'm showing you here on the right is deoxyglucose. This is something that cells will take up, particularly in the brain, because they use glucose for energy. They look at the deoxyglucose, they say, hey, there's some glucose, but it's actually deoxyglucose. So they take it up, they try to use it for energy, and they can't. So the deoxyglucose gets stuck inside the cells. Well, what good is that? Well, it gives you information about which cells are trying to take up glucose, which is what they should be doing, and maybe more importantly, gives you information about which cells are not trying to take up glucose like they should be doing. So that's one example of a radioisotope. You can attach a radioactive atom to whatever you want if you're a smart enough chemist to figure out how to do it. So we have ligands, they're called, which are the compounds that have the radioactivity on them, that can bind to particular kinds of chemicals in the brain, that can bind to particular kinds of receptors on the cells in the brain, that can bind to transporters in the brain. And one of the ones that we're very excited about is a compound that binds to amyloid. Has any of you heard of amyloid? Why do I care about amyloid?
Alzheimer's.
Yeah, Alzheimer's. So amyloid protein is part of the pathological definition of Alzheimer's disease. If you don't have amyloid protein accumulating in your brain, then you do not have Alzheimer's disease. Well, the only way that we could tell that until recently was to take out a chunk of your brain, look at it under a microscope, stain it for amyloid, and see if it stains. Now, in a way, we inject that stain into the veins. There's radioactivity attached to it, and so our radioactivity camera picks it up and tells us, oh, this person has a bunch of amyloid accumulation. So this is an example of a non-neurologic use of a radio tracer. This is fluorodeoxyglucose, so the same stuff I was telling you before that cells take up when they're active. Now, on the left, you see someone who's got these dark spots all over. And the dark spots are areas where the radio tracer has accumulated. So those are areas where there's lots and lots of uptake of that radio tracer. Those cells are using a lot of energy. And the reason is that those are cancer cells, and they're actually those are not just cells, those are nodules spread throughout this individual's body. On the right is someone after treatment, and a lot of those have gone away. And you can see the power of using this as opposed to cutting open the arms and legs to see where the tumors are, to see whether the treatment is working. Now, there's still some dark spots here, right? So what is that dark spot? Brain. Why would the brain be dark? Is it full of cancer? High metabolic rate. So there are certain organs in our body that really are churning out lots and lots of processing and lots of energy. So you will still see some dark spots because the tracer accumulates in whatever cells are using lots of energy, whether those cells are supposed to be there or not. And in this case, they're supposed to be there, so that's the brain. What about that? This is a picture looking at someone from the back. That might help. That's the heart, yeah. So another area that's got a high metabolic rate. Also blood concentrates there, right? So you'll get radio tracer accumulating there. What about those?
Kidneys.
Kidneys, right. Everything's got to go through the kidneys in terms of the blood. And then what about that? Bladder, right. Not because of high metabolic rate, but because the radio tracer accumulates because it's being filtered out of the blood by the kidneys and going down to the bladder. And so you get a high concentration of the tracer there. And eventually we can take a PET scan of the toilet, and that's where the tracer will be. And you can do all kinds of things with PET scans. So on the right here, you can do color mapping instead of black and white mapping. And you see essentially the same structures. This is a different individual, but also with a lot of metastatic cancer. Here's how we use it in dementia. So at the top, you see 3 brains. The one on the left is a normal 85-year-old. The one in the middle is someone with Alzheimer's disease. And you can see that toward the back of that brain, there's much more blue and yellow as opposed to the front where you see a lot of red and orange. Those cooler colors, the blue and yellow, or the blue, green, etc., those are areas where there's less metabolism. And so this is the typical sort of pattern of Alzheimer's disease on a PET scan, that the back part of the brain is less metabolically active. On the other hand, with frontotemporal dementia, or Pick's disease, the front part of the brain is less active, as you see here on the right. So that's one use of PET scan, and this is a PET scan that's looking at metabolic activity. Now, you can also do the kind of PET scan that I was talking about earlier, where the radiotracer goes in and binds to amyloid. And in this case, a normal brain, you want to see low radioactivity, right? Because that means there's not a lot of amyloid. Whereas with the glucose, the deoxyglucose, you want to see high activity because that means your brain is doing what it's supposed to do. And on the right, you can see all this red. That's someone who's got a lot of amyloid buildup. But the real power of this may be in the patient in the middle, where this is an individual who does not have dementia, actually does not have any cognitive symptoms, and yet has a lot of amyloid accumulation, which means that this person is at risk for developing dementia. This person probably has Alzheimer's disease and is at risk for developing the end consequence of Alzheimer's disease, which is dementia. So in the future, we think we're probably going to use a lot more functional imaging than we do now, because function in the brain usually changes before structure changes. PET scans in the brain change before the MRI scans change. And we want to be able to take advantage of that to predict what's going to happen to people instead of telling them what happened to them 20 years ago. We are trying to get higher resolution of our nuclear images. If you compare those PET scans to the MRI and CT scans, they're a lot blurrier, right? It's a lot harder to see the individual structures. And if you want to look for small structures on PET or SPECT scan, it's pretty much impossible. You cannot get that information. So we can only look at really sort of broad areas, whole lobes of the brain. And then there are other types of imaging technologies. There are technologies that take advantage of electric currents in the brain, magnetoencephalograms, and we'll be using more and more of other types of technologies, and also new technologies that allow us to display things better. So I'm thinking of, those 3D printers. Have you heard of those? I mean, imagine if instead of handing you a stack of slices through your brain, if we could hand you a model of your brain and point to the areas that are shrunken or where there's disease. I think that would be a very powerful tool for us to help patients understand things better, but even to help us understand things better. And increasing use of imaging as a biomarker. So a biomarker tells us something about a disease that's happening inside the body. It's directly related to the disease, but it's a way of finding out about the disease without having to do a biopsy, for example. And we need to use imaging much more as biomarkers. They are biomarkers now, but not with the kind of accuracy that we would like to see. You had a question?
My son, when he was young, had ADD, ADHD, and one thing that was very helpful was biofeedback, and they did a imaging of the brain in a color-coded engineering, kind of like, where, with ADD, the frontal part of the brain is where the majority of the reasoning and logic happens, and the side lobes, the least is in the back. So they're looking for the neuron proton activity of the front and the side, and they could see if it's a deficit or not by the colors. I didn't quite understand it, but they showed me the result of it. Maybe you could touch base on what actual technology is.
It's hard to say because we can take anything and display it as a picture, right? Any type of information. Most commonly, the types of images you're talking about, color pictures of the brain, come from PET scan, but we also can make color pictures of the brain with MRI scans and with functional MRI scans, and even with EEG, which is just a recording of the currents that are reaching the surface of the brain.
Put sensors on his brain.
If they just put sensors on, then it must have been some kind of EEG-derived image. But that's one of the things that's becoming more and more important with computers. We can really image things the way we want to. We can take huge amounts of data and make them into any kind of image that we'd like. We just have to come up with images that are more useful than the ones we have now.
It was very helpful because you, as a parent, could see what's going on in there, and it kind of explains why he's having all these symptoms and problems.
Yeah. Yeah, visual stimuli really help humans to understand things. Let me just go ahead and take other questions. Is there anyone, let's check with the remote site first. Then, Paramp? You had a question?
In transient global amnesia, would that show up on one of these scans?
Transient global amnesia. So the question was whether transient global amnesia would show up on one of these scans. Transient global amnesia is when, for a period of time, an individual is not able to form new memories. It's almost like having Alzheimer's disease, severe Alzheimer's disease, for several hours, sometimes as long as a day or two. We're not sure what causes it. The presumption is that during that time we would see less activity in the hippocampus, which acts like sort of a tape recorder in the brain. And there have been some studies looking at blood flow to the hippocampus that indicate that during the transient global amnesia there's a little bit less blood flow. But it's hard to catch someone when this starts. I mean, usually when this happens, it takes a few hours before anyone realizes what's going on, that this person is having a problem. And so most of the imaging studies that have been done in people with transient global amnesia have not come up with anything. That's probably because they've caught it too late. So I would say that theoretically we would expect this to show up on a functional imaging scan, not on a structural scan, but on functional imaging. But we would be much more likely to catch it toward the early part, the first hour or two of the illness. And most of the time when people go into an emergency room with a memory problem, they're not going to get a functional scan, they're going to get a structural scan, MRI scan or CT scan of the brain, to make sure that there's not a bleed, make sure there's not a stroke, because those are things that you have to fix right away. Transient global amnesia, we don't know what causes it, but it's temporary and not as critical to diagnose as a stroke, let's say.
If it continues to happen?
If it happens repeatedly, then what?
Then what?
You mean like would the scan pick it up, or?
Right, if it keeps happening, and you went right away.
Mm-hmm. Presumably, if you went right away and you had good enough imaging technology, you should be able to see it. The question is whether the imaging technology is good enough. This is probably a pretty small area of the brain that's affected, and our functional scans don't have the kind of spatial resolution that the structural scans do. So I think that if your imaging had high enough resolution, you'd probably be able to pick it up, but the question is whether the resolution is high enough.
So you mentioned a stroke, having a stroke. Okay, so if you have a stroke and you're not conscious, and they take you to the ER and they decide to do an MRI, and you have a stent, or you have dental work, you know, with post,
Mm-hmm.
and you're not conscious when they're doing this, does the machine alert the technician to stop?
Yeah, when it sucks the heart out. No, so generally people will not go into this, people will not be put into the scanner until they have gone through, well, they don't have to be conscious, but someone has to go through a questionnaire that asks them about all these possible things.
Yeah.
And that person has to know that they can't say, well, maybe or maybe not. And the other things we can do, we can take an X-ray. X-ray is very good at picking up metal. So if there's metal in there, you'll be able to see it.
I have no clue. I have a couple of, I had a car accident, I lost 2 teeth,
Mm-hmm.
and I have posts, they look metal to me.
Yeah.
And I don't, I don't really.
Sneak her into the scanner right now.
So they take an X-ray and they can tell you what kind of metal is in there?
They can't tell what kind of metal. They can say if there's metal and whether they need to be more careful.
Put a magnet
And
there
then,
and see if it sucks it in.
yeah, that's right.
All right. Because I was concerned.
It's like when you go to the recycler with metal to recycle.
Yeah,
He has
pulls
a
it
little
out.
magnet there, and if it's iron, he says, no, that's we don't, but if
Right.
it's
I don't know about that. Or if you'd want to recycle your posts. But